السلام عليكم.
السلام عليكم.
Yes, good afternoon, everyone. Welcome to our academic activity for today. Today we have three interesting lectures. The first one will be by Dr. Faisal Ghamdi about conduit choice for coronary artery bypass. The second will be Cabbage in acute myocardial infarction by Dr. Abdulaziz Al-Shimmari. And we'll end by coronary trial by Dr. Khalid Al-Garni. We have three guest consultants today. I would like to give them a warm welcome to our activity. Dr. Shabir Shah, who's a consultant cardiac surgeon at King Fahd Medical City, and Dr. Bakir, who's a cardiac surgery consultant at King Saud University Medical City, and Dr. Abdulaziz Baradei, consultant cardiac surgeon from Al Babtain. So I would like to welcome all of them to our activity, and we'll start in 5 minutes past 1. Faisal, I think you can prepare your slides. فيصل.
إيه هلا، السلام عليكم.
عليكم السلام ورحمة الله، تفضل.
Okay. Assalamu alaikum. Hello, everyone. This is me, Faisal Ghamdi. Today, I will talk about conduit choice for coronary artery bypass surgery. I will be mainly talking about my outline. I will be talking mainly about venous grafts and arterial grafts. I added also two more subjects which are flow measurement as a quality control tool intraoperatively. And I will be reviewing very quickly the guidelines regarding the conduit choice from different guidelines. So first, I will start with the venous conduit. We have multiple venous conduit that can be used for Cabbage procedure. We have the greater and lesser saphenous veins and the cephalic veins. But I will be mainly talking about greater saphenous vein, which is the most common used graft. It has multiple advantages like the ease of harvest, and it is readily available. It is versatile. It is resistant to spasm, and its long-term results have been thoroughly studied. It has a disadvantage, which is low patency rate. There are 5 main points about the greater saphenous vein that I will be talking about. Anatomy of the greater saphenous, and also I'll mention the lesser saphenous, the histology of the saphenous vein, some physiological aspects, and some about the patency rate and the harvesting technique. So the greater saphenous vein is a subcutaneous vein of the lower limb. It drains mainly the skin and the superficial tissue of the lower limb and the lower abdominal wall and pudendal region. It is a delicate bicuspid. It has valves that are delicate and bicuspid, like all other valves. It starts mainly from the ankle, anterior to the medial malleolus. Let me just use a pointer, yes. It starts here from the medial malleolus, anterior to it, and goes up the lower limb. Then it goes behind the knee about 4 finger breadth. It is in close association with the saphenous nerve, which makes it at higher risk of injury during harvesting. And it goes all the way over the medial aspect of the leg until it goes into the the femoral canal. The lesser saphenous vein starts from the lateral aspect, posterior to the lateral malleolus, goes all the way up the midline on the posterior wall of the lower limb until it goes into the gluteal region, where it goes deeper into past the deep fascia. Histologically, the saphenous vein, its intima, is lined by an endothelium that lies on a more fenestrated basement membrane. It has the cell junction of this endothelium, the endothelial cells, are mainly more permeable, and that's what makes it more prone to development of atherosclerosis and It has a poorly defined internal elastic lamina. The tunica media of the vein is thin compared to the arterial media. That's why it's resistant to spasm. And it is composed of smooth muscle cells. It has also a thick adventitia. One interesting information I found that the saphenous vein grafts are often seriously diseased in patients who are in their 6th decade of life. In a study a histological study, they found microscopic intimal hyperplasia in 95% of the saphenous veins in patients in their 6th decade of life. And that was due to phlebiosclerosis mainly. This is just a cross-sectional of a microscopic view of the saphenous vein layers. You can see how the endothelium has some spaces, and I think these are the fenestrations that makes it more more at risk for intimal hyperplasia and atherosclerosis. The physiologic points I want to mention about the greater saphenous vein is that it's inelastic when exposed to arterial pressures. It has a slower rate of lipolysis and more rapid uptake of lipid and more active synthesis of complex lipid compared to arteries. It is also more susceptible to thrombosis. Regarding the patency of the greater saphenous vein, it has a high failure rate compared to arterial conduit. The rate of the saphenous vein graft failure in the first year to the sixth year, it's 2% per year. After the sixth year, it's 4 to 5% per year. In general, 10 to 25% of the grafts fail by 12 to 18 months, and only 15% of the grafts are patent by 10 years. But that does not mean they do not have evidence of atherosclerosis and narrowing, but it's not significant. There are three types of graft failure when it comes to the saphenous vein. The first type is the early failure, which happens within the first 30 days post-op. It happens mainly in 10% of the grafts, and the main pathophysiologic mechanism is thrombosis. And it happens due to three main reasons, and you can recognize these reasons are part of the Virchow's triad. These reasons are stasis, hypercoagulability, and endothelial injury and cell loss. Stasis can happen mainly in a vein graft because of technical issue like kinks or poor distal runoff, or because of problems with the conduit itself, like a narrow vein, like a vein that has a small diameter. Hypercoagulability, any condition that makes the patient hypercoagulable or a disease. Thrombosis can happen due to endothelial injury in the veins, and the mechanism of endothelial injury can be due to mechanical trauma during the harvesting, the hemodynamic stress caused by the arterial pressure, which is the saphenous vein grafts is not used to, and also the vein walls, since we said are inelastic, when they are faced with the arterial pressure, they do not expand properly and they cause turbulence of flow. That turbulence of flow can also lead to endothelial injury. At the end, if this thrombosis does not cause early failure, it will be the grounds for intimal hyperplasia, which is the mechanism for midterm graft failure, which I will be talking about now. The midterm graft failure, it mainly happens between the 12th and the 18th months. The main mechanism is the intimal hyperplasia. And intimal hyperplasia is defined as the accumulation of smooth cells and extracellular matrix in the intimal compartments. So this intimal hyperplasia, if it does not cause enough narrowing, it will pave the way to atherosclerosis because it's the area where lipids will accumulate and cause plaques. At the end, in this slide, I want to mention something about the PREVENT-4 trial. This trial was mentioned in the textbook, and it's also a famous trial. It's a phase 3 randomized clinical trial of a medication of idefovligide. I hope my pronunciation is correct. So this trial was trying this medication, which hypothesized that this medication could lower the rate or prevent intimal hyperplasia in venous graft. But the trial showed that it made no difference and it was not protective. But this trial has undergone multiple analyses, retrospective analysis of its subjects. And these analyses gave us some idea about how the venous graft patency rate and natural history. So in a post analysis of this trial, they found that there are factors that predict failure of this graft, like longer surgical duration, endoscopic vein harvesting, poor target artery quality, and post-operative use of PTY12 receptor blockers. The last
Faisal,
type of Sami.
I wanted to ask about the endoscopic and the open technique. What makes it يعني, more susceptible for occlusion in endoscopic one?
We will. There is a slide about comparison. At that time, I can mention some of the way I think it causes this high rate of graft failure.
Okay, sure.
Regarding the late graft failure, which is the last type of graft failures in the saphenous vein, it happens after the first 12 to 18 months. It is when areas of intimal hyperplasia undergoes lipid deposition at that area causes atherosclerotic plaques. And the saphenous vein graft atherosclerotic plaques are friable and poorly calcified, which make them at higher risk of rupture and occlusion of the graft. Predictors of late failure are maximal stenosis of the graft at baseline angiography, elevated triglyceride level, small minimum graft diameter, low HDL cholesterol concentration, high LDL cholesterol concentration, and high MAP and current cigarette smoking. Methods or ways to prevent graft failure, or to at least slow the process of graft failure. First is the use of antiplatelets. Dual antiplatelets is a one way, but the most important medication is aspirin. Aspirin was proven to reduce the risk of graft failure. It reduced it it has a 41% reduction of SVG graft failure. While clopidogrel had different results. It was in the studies that were done on clopidogrel were not uniform in confirming that clopidogrel showed any benefit in addition to aspirin. So the most important in aspirin is aspirin. The second thing is statin. Our LDL target is to have the LDL less than 100 milligram per deciliter. Also, we have to achieve blood pressure goals because high blood pressure can cause intimal hyperplasia, and avoidance of smoking and blood glucose control. Contraindication for the use of saphenous vein graft is local cellulitis or thrombophlebitis, venous thrombosis, previous vein stripping or vein manipulation, increased vein branching, varicosities, wall thickness, and decreased diameter. Now we will go to the topic of saphenous vein harvesting. We have mainly three ways of harvesting the vein, either endoscopically or open, and for that we have either completely open wound or bridged, and the no-touch technique. The same trial I mentioned, which is the PREVENT-4 trial, they found that endoscopic harvesting was one of the risk factors for graft failure. At 3-year follow-up of that trial, they found that patients who underwent endoscopic vein harvesting had a higher death, 7.4% in comparison to 5.8% in open, with an increased risk also of myocardial infarction and repeat revascularization. But one thing we need to know about that trial, it was not designed for this, to study this, the difference between endoscopic and open. So the choice between which technique to use was not randomized. Also, this is a systematic review of endoscopic versus open technique. They found that endoscopic reduced the amount of postoperative pain, wound infection, and the length of hospital stay, while they found that endoscopic vein harvesting was associated with increased odds ratio of vein graft failure. So before I speak about this point regarding Ayat's question, I really did not read something that is factual about why it causes that. But when I saw videos about endoscopic vein harvesting and how it is done, for me, it looks the endoscopic has more manipulation of the vein, which makes it at higher risk of injury. While the open, you can do it almost completely without touching the vein. That's why I think endoscopic has the potential of having higher graft failure. But till now, there are no confirmed evidence. It's only retrospective analyses and systematic review of these retrospective analyses.
I saw it before myself. I've done it with assistance before, but yes, there is too much manipulation, as you said, but I was not convinced that this is the reason. That's why I'm asking.
Well,
if anyone can tell us.
What do
if you don't
think,
mind, Faisal.
No, that's okay. It's a discussion. Does anyone have anything to add regarding endoscopic and why it has the potential?
Yeah. Salam.
Alaikum salam wa rahmatullah.
Yeah. So what I know that, as you said, Dr. Faisal, the more manipulation of the vein, the more injury for the vein. This is one. And what I've read in some article that the temperature may play a role in the vein failure. So yeah.
Yes, what I saw, Saphenous, the endoscopic was mainly manhandling the vein, actually. It was very rough and there was a lot of stretching of the vein, and that could make it at risk of endothelial injury. What do you think, Dr. Bakir? Maybe he does not hear me. Okay, maybe he's busy now. So I will just continue. So regarding the Saphenous vein harvesting.
Can I just comment about
We have Dr. Abdulaziz with us.
Yes.
First of all, endoscopic technique is evolving technique. And at the beginning, I agree with you. The recurrence or low patency with endoscopic technique is more because they had heat and all this. But now with the newer technique and with the new instrumentation, I think it's the same. Even I once I gave a talk about this at the Saudi Heart and in one of the meetings. Even the people who are trained to do it, their patency rate is the same as people who are doing it more. So I kindly, disagree that the patency rate is lower. I think if you look in the recent literature, I think it's the same, to be honest with you. So that's my comment about endoscopic. And we were doing it, and I've been doing it for the last 3-4 years, and it's very good. But you need a good operator to do it. I agree with you, and things will be fine. Thank you.
And this is what I saw, Dr. Al-Baradi. I saw the patients, they had good results with the endoscopic. That's why I'm asking.
Faisal?
Yeah. It's very bad, especially with the now you are dealing here in our population. We have people who are diabetics, who just like I've seen very bad wounds in open technique. Now with this, I think it's much better. Even the results are better, and people they don't. The only thing is hematoma. Sometimes they develop, and also I want to give one thing is before harvesting you have to give heparin because to prevent any clot formation in the vein itself. And I've seen those clots from harvest veins. Thank you.
Thank you.
Salam alaikum. Faisal?
عليكم السلام ورحمة الله.
I was there, but there was problem with my microphone.
No problem, Doctor. Send.
Okay, and I agree with Dr. Badi طبعا. يعني it's like any new technique. It needs a learning curve and experience. So you should have a highly experienced operator to do the endoscopic harvesting. That's why at the beginning, there was bad results for early graft failure. But after that, I think the results now are improved a lot. This is what I think.
For me, I am biased toward open because to give me chance to work more. الصراحة.
Yeah, I will tell you my bias, but after you finish, just go ahead. I will tell you my bias.
Okay. So for the one of the points regarding saphenous vein harvesting, there was also an analysis of the subjects of PREVENT 4 trial regarding what is the best solution to preserve the vein. And they found that a puffered saline was associated with lower risk of vein graft failure. This is just a picture showing the two different open technique, either completely open or bridge technique. Now I will show you a video for the technique for harvesting the vein. It works. Can just give me a moment. Sorry. Sorry, it has some music, so if anyone does not want music, I'm sorry.
It's not playing, Faisal.
It's not. Can you see it now, or any issue with it?
No, we cannot see
it.
it.
Sorry.
Still, we can't.
Oh, I'm sorry. Sorry, my mistake. I will try again. Yeah, can you now see the video?
Yes.
Oh, I'm sorry.
There is no sound. They are commenting.
So there is no sound. I can do it on my own. So I can play the video.
If you want the sound to be transferred, you have to keep your mic open and keep it high volume.
My mic is open during the whole video, and it is high volume already. I will try one more time. If was there any sound?
Maybe if you have a headphone, you disconnect the headphone. Maybe sometimes.
I don't know. I can narrate over the video if you don't have any problem with that. Okay. So for the vein harvesting to be done, your incision has to start anterior to the medial malleolus, mainly, as you seen in the video. And from there, you can identify the saphenous vein graft. It is the best landmark, because this is what I learned, is by the posterior tibia. If you do an incision over that area, you will find the vein most of the time. But be careful with your first incision because the vein is very superficial in thin patients, especially at that area. And then after you find the vein, you keep following the vein and be careful not to create any skin flap. So when you use your METs, while dissecting bluntly with your METs, you have to go directly over the vein. Sometimes you can just dissect by putting the METs in and out. You don't have even to open it. And then you continue following the vein until you get the desired length. What I was taught how to measure the length of the vein graft is 1 DeBakey length, 1 DeBakey forceps length is equal to 1 graft. So each DeBakey is 1 graft. And our hospital, we try not to go over the knee because of the wound healing will be more difficult at that area. So you keep following the vein. Once you have exposed the subcutaneous tissue and you have inside the whole skin and the subcutaneous tissue, you can start dissecting the fascia above the vein. And you go carefully without injuring the vein. One thing I have to learn the hard way is whenever you go with this METs and inside the fascia, never close the stir until you are away from the vein. So keep incising over the fascia until you remove it fully. Then you go over the vein again systematically through each branch and isolating that branch, dissect it bluntly from around it from any connective tissue, and then ligate it with whatever the surgeon prefers, either with a silk suture, a silk tie, or a clip. And you have to ligate it both close to the vein and distal to it. But when clipping the vein proximally, you have to keep it flush with the vein surface to not create any stump for thrombus formation. Then after clipping all the branches, you cut it distally from the ankle, then cannulate it, tie the cannula, and flush the vein with either heparinized saline or blood, but flush it gently, not to over flush it or with a higher pressure to not cause any intimal injury. Then before cutting the proximal end of the vein, confirm with the surgeon the desired length, and then you can cut the vein proximally and put it in the preservation solution that your institution uses. Let me just see if, the cannulation process. Yeah. And then after cutting the vein, you have to ligate both proximal and distal stumps properly. I try to do it twice because to be more careful with a clip and a tie. And then after that, you close the skin and subcutaneous tissue in layers, depending on how deep is your wound. I hope what I said made sense. So now resume the rest of my presentation. Sorry, I'm just having some trouble with the PowerPoint. Can you see this now?
Yes.
So, I'm sorry. Okay, so after that, I will the complication of the saphenous vein are mainly wound infection, paresthesia, hematoma, especially in the endoscopic way, and edema and pain, post-operative pain. After that, sorry. Regarding the arterial conduit has advantages, which is the superior long-term patency compared to the saphenous vein grafts. The patency rate for arterial graft is around 10 years, in 10 years, it's around 98%. The disadvantage is the technique for arterial grafting is more challenging and time-consuming. Also, the harvesting techniques. We have multiple grafts. The first one is the internal mammary artery. So I will first start with the anatomy. The internal mammary artery originates from the first portion of the subclavian artery. And then it descends inferiorly at the level of the clavicle and the first rib, passes downward behind the subclavian vein and lateral to the innominate vein. At this point, by the first rib and the clavicle, the phrenic nerve crosses the left anterior, the internal thoracic artery. And at this point where the injury for this nerve is higher. Then it goes downward below the first costal cartilage. The ITA descends almost vertically and slightly lateral to the at a short distance from the margin of the sternum. The internal thoracic artery lies posterior and inferior to the cartilage of the upper sixth rib and at the intervening internal intercostal muscle. In the upper chest, there is a bare area in the upper portion or the upper third of the sternum. There is a bare area of variable length, and this is where you can expose the internal thoracic artery for harvesting. In this slide, you can see the relationship of the phrenic nerve with the internal mammary artery, either the right or the left. So the most commonly it goes superior to the internal mammary artery, but sometimes it can go inferior. When we say superior, it is in relation to you as a surgeon. You see it above or below the artery. But in relation to the patient, it's either anterior or posterior. Superior equates to anterior and inferior equate to posterior. So the benefit of the internal mammary artery over the saphenous vein graft and mortality has been consistently observed irrespective of the other patient's variable. So the benefit of the internal mammary artery over the saphenous vein graft and mortality has been seen consistently, regardless of the age or gender or degree of the stenosis of the coronary artery. The famous surgeon with the famous studies that found that is Floyd D. Loop. He had multiple studies, one which was done in 1986, which showed 10-year survival of patients who received internal mammary artery graft to the LAD, with or without a vein graft. And he compared that to patients who received only venous grafts. Another study that showed that is this one, which was done by Lytle, which showed that the same thing, the internal mammary artery benefit for mortality when anastomosed to the LAD. And this one was on a longer follow-up, 18 to 20 years. The internal mammary artery has, as I said, good clinical outcome, and the use of the internal mammary artery and the risk of the use of the internal mammary artery, even during reoperation, was not found to increase the risk of reoperation. And it was found that the use of internal thoracic artery is protective against the risk of future reoperation for patients undergoing Cabbage. So the physiology of the internal mammary artery and the histology, it has a more resistant endothelium against harvest injury, unlike the vein. It has a thin tunica media. The intima of the left internal mammary artery consists of endothelium with few fenestration and low permeability, unlike the vein. And the intima endothelium is rich in antithrombotic molecules. And the lima has a flow rate that is similar to the coronaries, which makes it even more at a lower risk of occlusion or thrombosis. This is a table I got from UpToDate comparing anatomic and physiologic characteristics of the internal mammary artery and the saphenous vein. You can see, as I said, that the internal mammary artery has fewer fenestration, with many intracellular processes, with fewer junction, unlike the veins. You can see that the mammary artery produce, the endothelium of the internal mammary artery produce heparin sulfate from the internal elastic lamina and media, unlike the vein. And this reduces the risk of thrombosis. In addition to other physiologic characteristics, like the mammary has a higher flow reserve, with resistance to a higher shear stress, and a production of nitric oxide and prostacyclin, which makes it dilate and adapt to the newer flow toward the coronary. And also these characteristics, as we will find later, also protect the coronaries from further coronary artery, from further atherosclerosis and stenosis and narrowing. Regarding the patency for the internal mammary artery, early patency is almost 99% for the left internal mammary artery, and 94% of the right internal mammary artery when the right internal mammary artery is anastomosed to the circumflex. Risk factors for early failure are either technical issues or patient-related. Technical issue, like either harvest problem or distal anastomotic technique that is not proper, and perioperative management, including use and timing of antiplatelet therapy and use of vasospasmodic medication, and not using the statin therapy. Patient-related, either anatomical issue, like the proximal stenosis of the internal mammary artery, or presence of competitive flow in the bypassed vessels, especially if the stenosis is not significant. And plaquing and diffuse disease in the bypassed vessels. Regarding the long-term patency of the internal mammary artery, it has a much higher patency with the left than the venous graft. The left internal thoracic graft patency is over 95% at 5 years and slightly lower at 10 years. Regarding the right internal thoracic artery graft patency, it is similar at 5 years to the left, but it falls below 90% at 10 years, especially if it's placed on the right coronary artery. You will notice that in the right coronary artery, the threshold for stenosis to use an arterial graft is higher than the left. That's because the right coronary artery is larger than the left coronary artery, which makes the risk of competitive flow higher. The internal mammary artery is superior to all other conduit regarding venous, whether venous or arterial. The lima has more than 90 over 10 years patency rate. The internal mammary artery patency, the causes of hyperperfusion when it is used, either mismatch between the graft and the recipient artery, or the infusion of high doses of vasoconstrictors, or a subclavian steal syndrome. Subclavian steal syndrome happens when there is a proximal occlusion of the subclavian artery, which causes the blood flow to go retrogradely from the coronaries into the internal thoracic artery, causing this steal phenomenon. For the internal mammary artery harvesting, the first thing you need to do after the sternotomy is exposure. There are multiple retractors that can be used. You have the sternal retractor, which you see here in the first picture with the blue handle. You have also the one on the left, which is this one. To position it on the table. I used to remember its name. I think it's Pavlo. This one is the rule track retractor. And also the table position, you have to adjust it to improve the left mammary artery. And the lung ventilation, you can reduce the tidal volume, that's one way. Or you can, if the patient's oxygenation is well, you can stop them completely for a period of time. In case for retraction, there are possible complications for retraction. One complication is sternal fracture, and this risk increases when your sternotomy is not centralized. Another thing is costochondral separation. And this complication is common with excessive retraction, and it is usually involves 2 ribs, and it requires no treatment and is not associated with significant postoperative pain. And the last thing is brachial plexus stretch injury. So avoid excessive retraction. There are 2 ways to harvest the mammary. You have the pedicle and the skeletonized. And the pedicle has the advantage of reduced spasm, while the skeletonized give you the advantage of longer length and low risk of infection and sternal infection and a better flow. This diagram you see here on the right shows you how skeletonized give you a better length, almost around 3 to 5 centimeters extra length when you do a skeletonized harvesting. I had a video regarding the internal mammary artery harvesting, but since we have experienced those issues before with the first video, I'll just mention some important points, which which I have mentioned most of them regarding the retraction and the exposure. And another thing you need to worry about is the phrenic nerve injury. Be careful not to injure it, especially as we said, the phrenic crosses the internal mammary artery. It goes from the lateral aspect of the chest to the medial, toward the medial aspect of the sternum at around the first rib or the clavicular level. Also, once you're done with the dissection, there are multiple methods to cut the internal thoracic artery. Some people leave it until the patient on bypass. Some people do it before putting the patient on bypass. But once you want to clip it and cut it, you have to give some heparin and wait for 2 to 3 minutes. And your distal extent for cutting is by the branching point, because the internal thoracic artery branches into the superior epigastric and the musculophrenic. So before that, you have to clip it. And these are the most important points that I remember. Sorry, same issue with the videos. Just fix it. Okay, so, oh my goodness, the same issue, sorry. Okay, so regarding the Verima harvesting, you have to do, while harvesting the Verima, you have to reduce trauma to the chest and preserve its collateral blood flow by doing the skeletonized method. Skeletonized dissection of the artery should be performed while harvesting the Verima. This was shown not to harm the conduit and extend its length. And it's particularly important in the right because the usual target lies further from the thoracic element, because the target for the Verima, if these targets were on the left side, they will be a little bit further, so we'll need that length. As I said, the additional length can be achieved with skeletonized. The Verima can be used as a pedicle or as a free graft. Sorry, as a pedicle or as a free graft. And it has shown the same patency and survival benefit. There is no difference. Excuse me, please. Yeah. So regarding routing the internal mammary artery, the shortest route from the thoracic inlet to the LAD is parallel to the phrenic nerve. So you have to have the internal mammary artery parallel to the phrenic nerve, and then you have to take it inside the mediastinum to anastomose it to the LAD. So one way sometimes you can get length is by incising the pericardium transversely from its midline, opening across the pulmonic valve to within centimeters of the phrenic nerve. This is something I have seen while incising the pericardium to get some length. If you are not careful, you could injure the phrenic nerve while doing that. So be careful before not to incise it fully, just before the phrenic nerve. If the internal thoracic artery is not intrapleural, it is always pushed toward or usually to the midline by the left lung. So you have to place the internal thoracic artery inside the pleural space and to have it under the lung. So to make reoperation safer. Contraindication to harvesting the internal mammary artery. Patients who have radiation to the chest, which might induce atherosclerosis, significant disease to the subclavian artery, which could cause Steele syndrome, extreme chest deformity, emergency situations because it takes longer time to harvest the internal thoracic artery, and those undergoing reoperation who have patent large. This one I read in one of the references, but I could not understand why it is a contraindication. Those people who are undergoing reoperation and who have a patent and large diameter atherosclerotic vein grafts, the replacement of which by smaller diameter internal thoracic artery grafts might result in hypoperfusion. Does anyone know or
Faisal?
Sami, Dr. Yes, Dr. Bakir.
For Redo, if you have a vein graft which is still supplying the LED and you need to put a mammary, never ligate the vein graft. You have to keep the vein graft, okay? Because the area is used to high flow from the vein graft, okay? And if the mammary does not give you this high flow at the beginning, so you have to leave the vein graft in its place, okay? Never ligate it and put the mammary distal to it.
Okay, I understand.
Okay.
So this is the ART trial, which is a trial that compared bilateral internal mammary artery harvesting. Unfortunately, I had my notes about it, but I forgot the details of this ART trial. I think Dr. Khalid will talk about it at the last lecture. Am I right, Luay?
We'll talk about the coronary trial.
The coronary trial. Unfortunately, I really forgot about these details. If anyone can...
I got this ART trial comparing the single versus bilateral mammary, and the results of the trial was almost neutral at the end, but there was a 40% crossover in the study, okay? And 25, almost or more than 20% of the patients who received the single mammary artery, they received the radial R3 in addition. That's why the results were not that satisfying, okay?
Okay, thank you, Dr. Bakir. This is also a meta-analysis that reviewed multiple studies that compared bilateral internal mammary with the
can you hear me now, Faisal? I'm sorry for interrupting you.
Yes, I can hear you.
I'm sorry for interrupting you. I think there is a Roma trial now. They will address the limitation of the Arte trial, the crossing over the 14 and 22%. So still undergoing the Roma trial for the arterial revascularization.
Okay, thank you very much, Faisal. So this is a meta-analysis that involved 27 observational studies, and it found a significant increase in long-term survival in patients who underwent bilateral mammary artery grafting when compared to Lima alone. But in this meta-analysis, there were no randomized control trials included. This is also another study that compared the survival of patients receiving internal thoracic artery with a single internal thoracic artery and followed them for more than 20 post-operative years. The cohort included 8,123 patients who received single internal thoracic artery and 2,000 patients receiving bilateral. They chose from those cohorts 1,152 propensity matched pairs. They found that bilateral internal thoracic artery grafting produced improved survival when compared to single thoracic artery. And this benefit extended throughout 20 post-operative years.
But you have to mention that the
about
benefit is after 30 years, no?
After 30 years.
After 10 years, you start to see the benefit of bilateral mammary.
I understand. So only after 10 years. So Dr. Bakir, does that mean if a patient's life expectancy is less than 10 years, we should avoid bilateral internal mammary artery?
It's not avoid, it's not, it won't be of great benefit. Yeah.
Okay.
But who knows?
So regarding the Verima, the Verima is a better second conduit when compared to the radial artery. It was found it's a better compared to the radial artery. Concern regarding the bilateral internal mammary artery is increased duration of the procedure, deep sternal wound infection, and the length of the right internal mammary artery, and the ability to use it to revascularize the circumflex system. So the increase in risk of infection, which was mainly found in diabetic, I read in one article that it was not, is it diabetes itself that is increasing the risk of deep sternal wound infection in patients with bilateral, or glucose control? I mean, if we use bilateral internal mammary artery grafting and we control blood glucose in patients who are diabetic, will that negate the risk of sternal wound infection or not? Because it was not clear from my reading that diabetes by itself as a disease is the reason for the infection. Maybe it's the blood glucose control. Now the second arterial conduit, which is the radial artery. Before I talk any more about it, I will just give a brief introduction. It was mainly first used by Carpentier in 1973. That was the first experience. And because of high graft failure, it was abandoned. In 1988, a Carr, which is a cardiac surgeon, after reports of patients with radial artery having patent grafts, he reintroduced it and found that there was, in his published experience, he had 100% patency in 56 radial grafts in 2 weeks after the surgery. So although long-term patency has been established, no study has shown higher survival rate. So even though it's not like the Lemia, it has a high patency rate, but there is no study confirming that it has a high survival benefit. Regarding the histology and physiology of the radial artery has a continuous intima of endothelial cells with a single elastic lamina and thick tonica media of smooth muscle cells. And this is the reason why it has a high risk of spasm. The radial artery shows a higher incidence of atherosclerosis compared with the lemma. Advantages of the radial artery, it can be easily harvested, and its length usually allows for all coronary territories to be used. Disadvantages, it's susceptible to vasospasm and intimal hyperplasia. The potential calcification, especially in patients with peripheral vascular disease. The need for proximal anastomosis, especially in cases where there is a calcified aorta and you want to avoid manipulating the aorta. And the radial artery patency is significantly influenced by the competitive coronary flow. That's why you will see there are recommendations to use it only for very severe stenosis, 90% or more.
It's 90, Faisal?
Yes, doctor.
It's 90%, يعني if you are reading to the right, but on the left side, you can go down to 80%. It should be okay.
80%, okay, thank
Okay,
you.
for the right, it's 90 or more.
Okay. Regarding the anatomy,
the other point is poor quality radial artery in diabetics. You know, most of our patients, and I don't understand this point exactly. Peripheral vascular disease, okay, but in diabetic patients, most of our patients are diabetic, and we can use the radial artery. I think it's with no problem. Yeah.
Okay.
Okay.
But doctor, patients with diabetes would usually sometimes have peripheral vascular disease, right? Or
yeah, patients with peripheral vascular disease, but not all patients. And yeah, it's only a few percent of them.
Okay. Regarding the anatomy of the radial artery, usually the forearm is divided into 3 segments: the proximal and the middle and the distal. But for the radial artery, it's mainly a branch of the brachial artery. It goes lateral between it goes between the biceps tendons and the biceps aponeurosis. It goes directly lateral and under the brachioradialis muscle, and continues under the brachioradialis muscle until it's near the distal region of the forearm, where it appears and become more superficial. Here it is bounded laterally by the brachioradialis tendon and laterally by the flexor carpi radialis tendon. Major structures that you need to know about with the radial artery and are important during dissection and harvesting I remember once Dr. Khalid Al-Ataybi last year, he said there is the rule of 2. You need to be worried about 2 branches for the radial artery, you need to know them, 2 nerves, you need to be careful around them, and mainly 2 muscles that you will be working around. So the 2 branches of the radial artery are the 2 extent of your dissection. There is first the recurrent radial artery, which is the proximal one, and distally you have the branch that goes to the superficial palmar artery. The 2 nerves are the lateral antebrachial cutaneous nerve and the superficial radial nerve, superficial branch of the radial nerve. These are 2 sensory nerves that supply the forearm, the volar part of the forearm, and the dorsal part of the hand, which can be injured during your harvesting. So as you see in this picture, which beautifully show you the superficial radial nerve, during your dissection and harvesting of the radial artery, in order to avoid injuring the lateral antebrachial cutaneous nerve, you have to dissect medial to it. You have to start your incision at this line away from because usually this lateral antebrachial cutaneous nerve is on the edge of the brachioradialis muscle. So if you go a little bit medial, you will avoid injuring it. And also regarding retraction, you have to retract. You should avoid excessive retraction because it could injure the lateral antebrachial cutaneous nerve and also could injure the superficial radial nerve. And the superficial radial nerve also can be injured while dissecting the radial artery and dissecting the side branches. Okay. So before harvesting the radial artery graft should be avoided in patients with chronic renal disease because they might need that radial artery for an AV fistula for the future dialysis. Also, patients who underwent transradial endovascular procedure like left heart catheterization, coronary angio. I read if a patient had a recent coronary angiogram, you have to avoid using the radial artery for at least 3 months. Then you might use it. But is that only a histologic study that showed that the radial artery recovered 3 months after the endovascular procedure. Also, the radial artery should only use to bypass severely stenotic coronaries, as Dr. Bakir said, for the right 90% because it's larger and 80% for the left system. For the radial artery harvesting, it can be done either an open or endoscopic technique. It is preferable to choose the non-dominant arm because this arm, one of the complications could be after harvesting paresthesia and temporary weakness. Also, you have to examine the hand circulation. One of the tests that can be used is the Allen's test, which is a good first-line test that can be used. You can do it also with the pulse oximetry to check the hand circulation and if it's patent, and if the hand circulation can depend only on the ulnar artery. This is a video, but I'm gonna face a problem actually playing it. So I am sorry, I will not be able to play it. But as I mentioned, there is the rule of 2, which is you have to be careful of the 2 nerves. Also avoid going too medial during dissection because you might injure the median nerve and the ulnar nerve. The median nerve and the ulnar artery, sorry.
Just excuse me, did you mention about if it's suitable to take it because of the circulation and not jeopardizing the vessel, and what tests you can do for this?
Yes, doctor. I mentioned the good first line test is the Allen's test, and you can use the pulse oximetry as an objective measure for circulation, and also the ultrasound duplex. Are there any other tests?
Okay, no, but just did you go into details? How do you do them and everything? Because this is very important. You're
yes,
just not mentioning the names.
I will mention.
What I mean, you have to tell us what Allen test, how you can do it, pulse oximetry, and how you can do it, and the others, how you can do it, because this is practical and you should know about it and let the other people know.
Okay, I will do, doctor. Regarding the Allen's test, the classic Allen's test is to raise the patient's arm and occlude both radial and ulnar artery. And then you wait and ask the patient to hold his fist forcefully. Then you release one of the arteries to check the patency of the other. So you can release the ulnar and wait and look at the arm. If the color changes from pale to red within around, I think, 5 seconds, that's a negative test, meaning that the ulnar artery providing good circulation to the palmar arches. And you can do vice versa for the radial artery. But in the OR, we use the pulse oximeter. We put the pulse oximeter on one of the fingers. When we do the same, we occlude both arteries until saturation is 0. And also waveform, sometimes you wait for it until it is flat. Then we release the inner artery. If we got a normal form, good saturation, that means it is a patent ulnar artery that can provide sufficient circulation to the palmar arches. Did I mention everything, Doctor?
Yes, and I think just the Allen test is a good tool, but I think pulse oximetry, everybody has to depend on the pulse oximetry in the operating room. I think that's the key for this, and it's your first choice to do.
Yeah, I agree with Dr. Barada. It's pulse oximetry is number one to do it.
Okay, but
you
we
put the
name it.
on the thumb or index, not on any finger. You don't put it on the little finger, for example. You put it on the thumb or the index finger, which is supplied by the radial.
Okay, thank you.
Okay.
Regarding the complication of the radial artery harvesting, you have wound infection, hematoma, compartment syndrome is a possibility with edema, and some neurologic complication, which in general are transient, are self-limiting. But if you injure one of the nerve, you might have paresthesia in the dermatomes supplied by these nerves, and also hand ischemia if you did not check the hand circulation before harvesting. For the radial artery patency rates and outcome, at 1 year, the radial artery...
Can I comment about this? Neurologic problems happen, and especially with cutting the nerves. I've seen patients, unfortunately, they have chronic pain in their hands for years, and we tried pain management. It's been tried this. So neurologic thing is just very important in this, and I think you have to tell the patient before you do this. It's like I don't know what is just because we say it's sympathetic or flush or something in the hand, but those patients after harvesting the radial vein, they really complain of very severe pain in their hands. So you have to be careful in harvesting those arteries. Thank you.
Thank you, Doctor. So regarding the radial artery patency rate, it's 96% at 1 year and 89% at 4 years. The rate of the radial artery patency is higher when grafted to a native coronary artery with more than 80% stenosis. So this is also an iteration of what I said, a reiteration of what I said, is you have to choose a severe stenosis, 90% for the right and 80% for the left. At the end of the arterial conduit, I will mention two other arterial conduit briefly. We have the Gastropublic Artery, which is a branch of the gastroduodenal artery that runs parallel to the greater curvature of the stomach. It has a thick, smooth muscle media that is prone to spasm. The 1 and 5 and 10 year patency are 91 and 80 and 62% respectively. The inside to gastropublic artery easily reaches the inferior wall, especially the PDA, without stretching. Contraindication for the use of this artery are diseases to the descending aorta, because it comes from the celiac trunk and from the gastroduodenal artery, and not a severe narrowing of the dominant right coronary artery. This is a picture showing just the anatomy of the gastropublic. Mainly the right gastropublic artery is what is used. You can see it's coming from the celiac trunk and common hepatic, then the gastroduodenal. Another artery also that needs to be mentioned is the inferior epigastric artery. It's a branch of the external iliac artery. It is 8 to 10 centimeters long. It is prone to spasm and therefore should be used in severely stenosed coronary, and the use of antispasmodic medication needs to be used post-operatively to prevent this complication. It is best used to bypass a severely stenotic coronary artery. The reported 1-year patency is about 90%. These last two arteries are rarely used due to it is very difficult to harvest them and morbid because it's an extra incision and it can prolong also the procedure. This is also a depiction of the anatomy of the inferior epigastric artery. The last slide regarding the allograft and the artificial grafts in this procedure. There are some experiments with cryopreserved saphenous vein grafts. There are also some bovine chemically treated internal thoracic arteries and synthetic grafts with the EPTFE grafts. These are all just experimental. They have not reached the clinical use phase till now. And from what I read till now, they have poor results. So that's why they haven't reached the clinical use phase. These are some tables comparing the different grafts we talked about in this presentation. I'll just go through them because some of them are just repeating what I said. One other important point is the flow measurement of the graft flow intraoperatively. So the flow meter, what we see in cabbages used commonly, has the technical term of this technology is transient time flow measurement. And it is one of the tools that for intraoperative quality control in cabbage. This probe, the probe that we see in the operation, has 2 transducers and 1 reflector. We put the conduit with any conduit, but we happen to use it in cabbage for graft flow measurement. And there are two ultrasonic waves going from the first transducer to the reflector, then back to the second transducer. Another one goes from this transducer to the other. And the time difference between them is the value that we get in the machine, which we call the mean graft flow, which I will talk about now. This technology has been found to detect at least 2 to 4% of the graft that require revision intraoperatively. This is a picture of the flow meter used in the intraoperatively with different sizes depending on the graft size. And this is on the left is the machine that shows the measurements and the calculations. So the parameters used or the parameters that this technology counts. First, we have the mean gradient flow and the pulse index. These are the most common values we see and are reported. The mean graft flow, it depends on the graft quality and diameter and target vessel quality and the distal runoff of the bypass. Regarding the pulse index estimates the resistance in the graft and respectively the distal target vessel runoff. The two last values are rarely, I only heard about them now when I read about this topic. The first one is the diastolic flow fraction. This one calculates the amount of flow that goes to the heart during diastole. And the systolic reverse flow, which correspond to the percentage of the flow curve area below the 0 line. If you see this, let me use my pointer. If you see this graph, this line or this curve is the calculation of the systolic reverse flow. The percentage of this curve should be at less than 3% to be normal. If it's more than 3%, it's counted to be abnormal. So regarding the cutoff limits for these values, for the mean graft flow, what I found that the European guidelines in 2010 had 2 values for mean graft value and the pulse index. But in 2018, they removed these values. They were not mentioned. The values were cutoff limit of 20 ml or more for it to be normal, whatever is the graft. And for the pulse index, it has to be 5 or less. That was what was mentioned in 2010 guidelines. But you can see here on the table on the right, this is a table I got from a review article reviewing multiple observational studies regarding what is the best cutoff limits. You can see, like, for the mean graft value, but one of the studies specified, one for the saphenous vein graft and one for the artery. For the Lima, it was less than more than 20, 20 or more is normal, and for the venous graft, 40 or more. Regarding the pulse index, they were all over the place, the numbers, but as I said, in the European Society guidelines, it was 5 or less were considered normal. There are no RCTs in the dosimetry cutoff limits. The only randomized controlled trials is the GRIP trial. The last part of my presentation is a review of the guidelines regarding the conduit choice. The first guidelines is the American Heart Association Cabbage guidelines in 2011. You can see it's class 1, level of evidence B, to use the Lima to LAD. And it's class 2A to use the Rima to LAD when Lima is not available. And the second internal thoracic artery to be grafted to the circ or the RCA when stenosed and perfusing LV myocardium. It's class 2B for the total arterial in patients who are less than 60 years with few or no comorbidities. Arterial grafting with the RCA when a critical, meaning more than 90% stenosis is present. The radial artery for the left side coronaries when it's more than 70% stenosis, and RCA more than or equal to 90%. It is harmful to use an arterial graft to bypass an RCA which is less than critical stenosis, that is less than 90%. The only guidelines I found that is only talking about arterial conduit are the STS, Arterial Conduit guidelines for 2016. It is class 1 to use the internal thoracic artery to bypass the LAD when bypass of the LAD is indicated. As an adjunct to the left internal thoracic artery, a second arterial graft, Rita or radial artery, should be considered in appropriate patients. Use of the bilateral internal thoracic artery should be considered in patients who do not have an excessive risk of sternal complication. As an adjunct to left internal thoracic artery to LAD, or in patients with inadequate left internal thoracic artery, use of the radial artery graft is reasonable when grafting coronary targets that have severe stenosis. When the radial artery grafts are used, it is reasonable to use pharmacologic agent to reduce acute intraoperative and perioperative spasm. The right, it is class 2A, 2B to use the right gastropublic artery in patient conduit options or as an adjunct to more complete arterial revascularization. There were guidelines, extra guidelines to reduce the risk of sternal infection in patients who will undergo bilateral internal thoracic artery grafting. It was class 1 to cease smoking. It was class 2A to use skeletonized graft, and glycemic control was also class 2A. It was class 2B to enhance the sternal stabilization to reduce the sternal wound infection risk. The review is the European Society Revascularization Guideline for 2018. For the conduit, it was class 1 to use arterial graft with internal mammary artery to the LAD system, and to use the radial artery over the saphenous vein in high-grade coronary artery stenosis. And class 2A to use, in addition to arterial graft, an additional arterial graft should be considered in appropriate patients, and bilateral internal mammary artery grafting should be considered in patients who do not have high risk of sternal wound infection. Regarding the harvesting technique, it was class 1 to use skeletonized technique to harvest the internal mammary artery in patients with high risk of sternal wound infection. And it was class 2A to use the endoscopic vein harvesting, and it should be performed by experienced surgeon to reduce the incidence of wound complication. And also class 2A to use the no-touch vein harvesting when an open technique is used. This is a table I got from John Hopkins' book comparing the different regarding the indication, contraindication of their use, and their failure rate. And thank you very much for listening to me. If there are any questions or addition, and excuse the technical issues I had during this lecture.
Thank you, Faisal. Informative lecture. Just one question for our guest consultants. Are we usually replacing our anastomosis if we are not happy with the flow meter results?
I think you should do it if with the mammary. It should be done. If you have a mammary with poor flow, high index, this should be repeated, whatever. No excuse to come out with a mammary with poor flow. For the other vessels, it depends. You have to look again. Maybe the vein is twisted. You are not sure. The other thing is if you have poor targets and you know the target is poor, maybe you cannot do it again. But if your target was good, you have to repeat it. Is clear? Am I clear?
Yes, Doctor. Thank you so much.
Yes, Doctor.
Okay. another
دكتور
point
بكير دكتور بكير شلونك؟
اهلا وسهلا.
How you differentiate between spasm in the left mammary or bad flow?
لا, you cannot differentiate. يعني both will give you poor flow.
Yes.
You cannot differentiate. Okay.
So even for spasm in the memory,
you can use papaverine and wait for some time and see. Okay. If it improves, okay. If not improve, you have to. There is something wrong with your anastomosis.
Okay.
The other thing which I do, and actually we all do now, we measure the mammary before flow before removing the cross clamp, and even the vein. You can measure the vein flow before removing the cross clamp. Okay. So you will be sure, almost 100% that your anastomosis is functioning nicely.
Okay.
نعم. الحاجة الثانية اللي هو كان فيصل ذكرها دلوقتي اللي هي non-touch technique for veins. I think you mean by non-touch technique using harvesting the vein as a pedicle, صح?
Yes, with the harmonic, I saw the video.
With a pedicle, I think yes. Harvesting the vein as a pedicle has very high incidence of wound complication. Okay.
Okay.
My preferred technique for veins, especially in patients with peripheral arterial disease, is the bridge technique.
But Dr. Bakir, I saw a video of this bridge technique. It is very traumatic to the vein. Like it's include twisting and.
The bridge technique compared to the endoscopic technique is much less traumatic. You need someone to assist you to raise the skin and subcutaneous tissue for you. You need someone to assist you. You cannot do it yourself. فاهمني? You cannot do the bridge technique yourself. It's very difficult. You will traumatize the vein definitely if you do that. last point اللي هي we have to use at least two arterial grafts for patients who are less than 60 years old. Less than 60 years old and using one mammary and veins, I think we are not doing the full job for them. If possible, if you can use two arterial grafts for those less than 60, it would be better. Okay.
It was class 2A. Yes, thank you, Doctor.
Yeah, even the use of the radial is class 1 now. If you in the last European.
Faisal?
Yes.
If you allow me, thank you for your presentation. I have two questions. So, did you came across any comparison between free mammary, or as a free graft, and regular lima in terms of patency?
I did not read the study, but in a review article I read that it says there are multiple studies that showed they were comparable regarding patency rates.
Okay. Another thing, what you will do if, in case if you have hematoma or dissection in the mammary during harvest? Would you use it or not?
This is for me the question.
Yeah, if you came across or for our guest consultants.
This section never use it, of course. This section you cannot use the mammary with this section. But if you have a small adventitial hematoma, it's fine.
Hematoma you can, Dr.
If it's small and you have good flow, if it is just a small hematoma and you have good flow in the mammary, you can use. But in the section, you can never use the mammary in the section.
I think if you have dissection, you cannot find any flow in the mammary.
There will be no flow. So you cannot use it.
Mm-hmm. Okay, because I've seen a case with dissection in the mammary, but it was good flow. But still,
but you want to go and sleep, yeah.
Yes. Yeah, absolutely. I just want to raise it because in case any of us face it. Thank you. Thank you.
The question, Dr. Bakir, if the flow is not that great and intraoperatively the cardiac, the heart is contracting very well and the echo is nice, do you prefer to repeat the graft, to repeat anastomosis, or?
Yeah, I told you if it is a mammary, you have to repeat.
Even the heart is contracting well and
yes.
Okay.
Any other comment or question for Faisal or consultant?
Yeah, I have a comment about the hematoma of the mammary arteries. I think if you see a hematoma on the mammary, I think this is maybe it's a hidden dissection. I believe strongly, and I was burned with one case where there was a hematoma and there was a good flow, and then at the end it wasn't. So we have to revise that coronary. And when we opened the coronary, we found the dissection in that. And this is the only thing we saw is just a hematoma on the dorsum of the mammary. So I believe if you see a hematoma, you have to be careful using that mammary, to be honest with you. And I don't know, this is just my feeling, and I wouldn't do anything. Or if the hematoma is distal, you can open the artery and see against that hematoma if the interior wall is okay or not. But if it is at the middle or proximal, I don't think you should use that mammary. Thank you.
Okay, thank you, Faisal, for the presentation. I believe we'll have a break for 10 minutes and then we'll start with the second lecture. I think we can start now with the second lecture. I would like to welcome again Dr. Abdulaziz Al-Baradei and Dr. Shabir from King Fahd Medical City. Abdulaziz, you can start now. Thank you.
Thank you so much, Luai. My talk today is about the role of the coronary artery bypass grafting in acute MI, especially in STEMI and cardiogenic shock. Can you see my slides?
Yes, we can.
Okay, thank you. So, as we know, the acute MI is causing around 30% die before reaching the hospital, and 5% die during the hospital admission. So the option for revascularization of occluded vessels is including the thrombolysis or PTCA, stent, or Cabbage. And our aim today is to talk about the Cabbage in such patients. The effects of timing with occlusion, if the occlusion occurred less than 20 minutes, so the myocardium will be reversible and the breast function with subsequent myocardial stunning. If the occlusion more than 40 minutes, but less than 3 hours, if the reperfusion happens, so 2/3 of the ultimate infarct is salvageable. If more than 3 hours, but less than 6 hours, the salvageable myocardium decreases up to 10%. More than 6 hours, it will cause transmyocardial infarction. As we know, the cardiogenic shock is defined with the clinical feature like the cold extremities, mental state changes, tachycardia with the hemodynamically, like the systolic blood pressure less than 80 and cardiac index less than 1.8, wedging pressure more than 18, SVR more than 2,400, and urine output less than 20 ml per hour. And the cardiogenic shock is the most common cause of in-hospital mortality after MI. The mortality reaching around the 80%, and the incidence is around 2.4 up to 12%. And revascularization within 6 hours has survival benefit, especially if the patient younger than 75. And the cardiogenic shock is due to the loss of at least 40% of the left ventricle. And patients usually have the extensive three-visit disease. And usually, as we know, the patient with the semi-patient is or the characteristics of the ST segment elevation, the chest pain more than 20 minutes, ST segment elevation in 2 contiguous leads, more than 2 millimeter in men and 1.5 millimeter in women, as we know, or left pentabranchial block, neo left pentabranchial block, or anterolateral ST depression. And the aim of the therapy is to decrease myocardial oxygen demand and the circulatory support and protect the threatened myocardium. The management of the semi-patient is, as we know, the monitoring, the central line, venous line, and all the management of semi, like the vasodilators in terms of nitroglycerin and analgesia with morphine and inotropes as the patient, if the patient required high inotropes. And this slides show the states of the myocardium. Usually in the infarcted myocardium, the viability of the cells is not viable and is due to the prolonged ischemia. On the other hand, the hybernating versus stunned, the stunned myocardium usually due to the acute insult and is the cause of injury due to the delayed with the reperfusion. And on the other hand, the hybernating is due to the chronic or ongoing ischemia, and the myocardium is viable. The randomized trial shown that the benefit effect of early reperfusion within 12 hours and possibly up to 24 hours after acute MI, and will come in the next slides. We'll talk about some studies about And our surgical strategy of controlled reperfusion in case of the patient with STEMI or cardiogenic shock and he underwent the Cabbage. So the bypass established as fast as possible to decompress the left ventricle. Antegrade cardioplegia should be given with either Bickberg solution to rebuild the ATP or high Ka cardioplegia to achieve the rapid diastolic arrest. Retrograde cardioplegia to achieve the global cooling. And after each distal anastomosis, infuse the cold cardioplegia into each distal and aorta around the 200 ml per minute for 1 minute, and then follow this by retrograde for 1 minute. And after the last distal anastomosis, warm the cardioplegia at 150 ml per minute for 2 minutes in each graft. And after removal of cross-clamp, regional blood cardioplegia is given to the area of the risk at 50 ml per minute for 18 minutes. Then you will do the proximals, and then the heart allowed to beat empty for around 30 minutes to decrease the oxygen demand. So what's the method of reperfusion in case of STEMI? Thrombolytic therapy. Thrombolytic therapy is decreasing in-hospital mortality in patients treated with streptokinase. And the study showed the superiority of the tissue plasminogen activator. It has more rapid and complete restoration of the coronary blood flow at 90 minutes and improve ventricular performance and reduce the mortality. And there is no benefit to add the glycoprotein 2B and 3A inhibitor or low molecular weight inhibitor, but it should increase the risk of bleeding. And cardiogenic shock use of thrombolysis doesn't seem to improve survival, but decrease the risk of developing heart failure. And survival is improved by decreasing time to reperfusion. And the GOST trial showed that the patient treated within first hour has the greatest improvement in survival, with 1% reduction in mortality for each hour of time saved. And according to AHA guideline 2013, in absence of this, in terms of thrombolysis or thrombolytic therapy, in absence of contraindication, fibrinolytic therapy should be given to the patient with a STEMI at a non-BCI center when the time between the first medical contact and to defuss or to the wire crossing more than 2 hours. And when the fibrinolytic therapy is indicated or chosen as a primary perfusion strategy, should be given within 30 minutes of the hospital arrival. So this slides from 2018 European guidelines show the total ischemic time of the patient diagnosed with the STEMI and non-BCI center. Of the anticipated time from diagnosis to arrive the BCI center is more than 2 hours, so the patient should receive the fibrinolytic therapy or thrombolytic therapy within 10 minutes. Of the anticipated time less than 2 hours, so the primary for reperfusion with the BCI strategy and should be less than 90. If the patient arrived in BCI center and from diagnosis up to the BCI, up to the wiring cross should be less than 1 hour. And this slides from the AHA guidelines, American College of Cardiology and American Heart Association, 2013. And mainly the STEMI patient, as you know, mainly is BCI and reperfusion with BCI. There is no, the role of the Cabbage is limited in STEMI patient or in cardiogenic shock patient of hemodynamic and stable. I will come in the next slides about that. So if the patient seen in BCI center, you have to send him to the cath lab within less than 90 minutes, and then BCI is class 1. The patient seen a non-BCI capable center and then send him to the BCI center within 2 hours of the anticipated time, as we mentioned before, less than 2 hours, send him to the BCI center, and should be the door in and door out. The patient admitted to that, to the non-BCI center, and then discharge to transfer him to the BCI center should be less than 30 minutes. So the time is very important in this patient. Of the patient, of the anticipated time more than 2 hours, the patient should receive fibrinolytic therapy, and then shift him to the BCI center within 24 hours. This is the category of the BCI after MI. The primary BCI is the method of reperfusion in patient presented with acute MI. Now, acute BCI because recurrent ischemia or hemodynamic instability after thrombolysis. Immediate BCI is BCI conjunction with the thrombolysis. Delayed BCI is BCI after thrombolysis during intervening the hospitalization. And elective is the BCI following thrombolysis and medical management when the positive stress test is obtained and during the same admission. So the evidence of primary, more than 20 studies have demonstrated superiority of BCI to thrombolysis. And it has lower mortality, reinfarction, stroke, intracranial hemorrhage. In case of immediate BCI, they didn't improve clinical outcome. In case of delayed, doesn't improve the clinical outcome. So the and combined with antiplatelet therapy gives superior result than balloon alone. Drug-eluting stent has lower composite endpoint of the death or reinfarction, or stroke, or angiographic evidence of stenosis. And according to the guidelines, the primary BCI in STEMI patient and ischemic symptoms less than 12 hours is class 1. Of the symptoms less than 12 hours and contraindicated to give fibrinolytic therapy is again the BCI is class 1. In case of cardiogenic shock or acute heart failure, acute severe heart failure is class 1. BCI of the non-infarct artery at the time of primary BCI is contraindicated, and we'll talk about that in culprit shock trial in next slides, inshallah. So the independent predictors of mortality is the age, hypotension, and lower TIMI flow, and multivessel disease. Now we'll talk about the role of the cabbage. Actually, as we mentioned before, the role of the cabbage has a limited role in acute phase of STEMI, other than for cardiogenic shock. So the indication of cabbage in STEMI patient or cardiogenic shock patient in case of failed BCI with ongoing ischemia or cardiogenic shock, coronary anatomy is not amenable to BCI, or in case of mechanical complication of the MI. In 2013 AHA guidelines, the urgent cabbage is class 1 if the coronary anatomy is not amenable to BCI, if the patient has ongoing or recurrent ischemia, cardiogenic shock, or manifestation of severe heart failure, or complication of MI like Phrenic receptor rupture or free wall rupture or ischemic MI. So the class 2A, the use of mechanical circuit support is class 2A in patient with STEMI patient for stability, for hemodynamic stability. In class 2B, emergency cabbage within 6 hours of symptoms didn't have cardiogenic shock and are not candidate for BCI or fibrinolytic therapy. The timing of urgent cabbage in patients with the STEMI in relation with the antiplatelet, dual antiplatelet. Aspirin should be discontinued before, should be withheld before urgent cabbage. Shouldn't be held before cabbage, should be continued the aspirin. Blavix or ticagrelor should be discontinued at least 24 hours before the urgent on-pump cabbage. Short-acting, the glycoprotein inhibitor like tirofiban should be discontinued at least 2 to 3 hours before urgent cabbage. The urgent of pump cabbage within 24 hours of Plavix or ticagrelor administration might be considered, especially if the benefit of prompt revascularization is outweigh of the risk of bleeding. Urgent cabbage within 5 days of Plavix or ticagrelor administration, or within 7 days of bra administration might be considered. So this is the timing of surgery. When we'll do the surgery, and this is a little bit controversial. The timing of after infarction of the surgical revascularization within 6 hours after the onset of symptoms is feasible. So the mortality rate is improved over the medical treated non-revascularized patient. And mortality for non-transmural group, we'll talk to now. If you see the non-transmural MI, the hospital mortality in terms of time of surgery, of the cabbage done less than 6 hours, you can see non-transmural group the peaked in the first group less than 6 hours, and then the mortality is decreasing. On the other hand, in the transmural MI, the mortality is high in the first 3 days, then decrease to 3%. So this is one study is published recently in 2020, and around 6,000 patients from 2010 up to 2014, as they include the patient older than 30 years old and diagnosed with STEMI who underwent cabbage within 7 days after urgent damage, after urgent hospitalization. And patient was divided in 3 groups. Group 1 is within 24 hours, and group 2 is within group B within 2nd or 3rd day, and group 4 with group 3, group C within from 4th to 7th day. And they found that the complication in the first group, which operated within 24 hours, is higher in terms of cardiac, respiratory, renal, and even the bleeding. And the complication between the group B and group C, which is from 2nd day up to 7th day, there is no difference, no significant difference. And if you see the mortality rate in the first group is around 8%, but in the other 2 groups, there is no significant differences between them. So they conclude that the patient who undergo cabbage within first 24 hours after non-elective hospital admission have increased hospital mortality and morbidity. And so they advise delaying surgery beyond the 24 hours may be beneficial to patient outcome, even in terms of cost effectiveness when the patient delays surgery, because the hospital length of the stay is reduced, as well as subsequent hospital costs. The other study is published in 2017 around 3,000 patient isolated cabbage patient with the prior MI from 2008 up to 2014, and they divide the patient and again to the four groups. The group 1 from within 1 day and group 2 within 2 days. Group 3 is 7 days, and group 4 more than 1 week. And they found in hospital mortality within the patient less than 1 day is around 5.4, and during within one week is around 1.8, 1.7 without any significant differences. And the mortality more than 1 week is a little higher than the group 2 and group 3, 2.3. And this is one of the limitations of the study, actually, because the characteristics of the patient. I will come for that for one slide about the characteristics of this patient. So they conclude that the patient operated on day 1 or day 2 and day 3 to day 7 after MI has similar mortality rate. and patient operated within 1 day after MI has had higher mortality rate. The patient characteristics of this study, the group 1 within less than 1 day is more likely have BCI or STEMI, and more likely ejection fraction less than 40 compared to the other groups. Even the left main stenosis more than 90, more than the other groups. On the other hand, if you see that the other group is more than 1 week, all the patients is associated with the comorbidities, and that may explain the higher mortality in this group, and this is one of the limitations of this study. And the other study was published in 2017. Again, they showed that the mortality is increasing significantly in patients who operated within 24 hours after MI. So we'll talk about the advantage of Cabbage in such patients. It's over the longest patency of revascularized arteries, over complete revascularization, and difficult distal obstruction can be reached, control reperfusion to reverse ischemic injury and reduce reperfusion injury. This advantage of early Cabbage, as we mentioned, higher mortality, but the results are not from randomized studies. All the studies is retrospective, and there is no now there is no any randomized trial about that. Availability of service in community setting. So the characteristics associated with the better early outcome after acute MI, especially with the patient with the preserved ejection fraction, with the male, with the younger patient, with the subendocardial MI versus transmural. So move on to the cardiogenic shock and Cabbage in patient with cardiogenic shock. Mechanism of cardiogenic shock in acute MI is commonly due to the LV damage, around 70%, and then due to ischemic MR and due to the complication of the MI like VSD or free wall rupture, around 5% VSD. And the shock trial in this such topic, they figure out of the early revascularization in patient with cardiogenic shock after acute MI. Actually, the shock trial is multi-center randomized trial, is around 300 patients with divided in two group, early revascularization, and the other group is initial medical stabilization and then revascularization after 55 hours, around 30 centers. Enrollment was 1993 up to 1998, and primary outcome was 30-day mortality. Analysis was intention to treat. So they include the cardiogenic shock within 36 hours of acute MI. And the acute MI, they defined acute MI according to the EKG, segment elevation, Q wave infarction, and a new left bundle branch block. And with cardiogenic shock by both clinical and hemodynamic criteria. Clinical criteria is hypotension less than 90, and need for inotropic support to keep systolic more than 90, evidence of end organ hypoperfusion. Hemodynamic criteria, cardiac index less than 2.2, and wedging pressure more than 15. And they exclude the severe systemic illness and severe valvular disease, dilated cardiomyopathy, unsuitable for revascularization. And the patient was randomly assigned within 12 hours after a diagnosis of shock to group 1 emergency revascularization, and around two-thirds underwent PCI, and 40% underwent the Cabbage within 6 hours of randomization. And the other group is initial medical stabilization with thrombolytic therapy and intra-aortic balloon pump, and then delayed revascularization at least 54 hours after randomization. So they found that in revascularization group, the mortality rate is, in 6-month mortality rate is around 50%, and the medical group around 63%. And the early revascularization group was the survival rate at one year, it was 46, and compared with the initial medical stabilization, it was 33, which is significantly differences. And an overall survival rate at 6 years, it was in the group with early revascularization, it was 32, and with the other group, with the medical stabilization group, it was around 20%, which is significantly differences. So according to the 2018 guidelines, they said if the coronary anatomy is amenable to PCI, so the PCI is class 1. If the coronary anatomy is not amenable to PCI, emergency Cabbage is class 1, or in case of hemodynamically instability, so the patient should undergo emergency surgical or catheter-based repair of mechanical complication. Routine use of the intra-aortic balloon pump in patient with the cardiogenic shock is not recommended. And we'll talk about that in intra-aortic balloon pump and shock 2 trial, inshallah. In culprit shock trial, and actually in this trial is cardiology trial, is not the surgical trial. They divide the patient in two group. The group with the culprit region BCI and immediate multivessel BCI. Patient came with the acute MI and divided into 2 groups. A group with the BCI only for the infarcted artery, and the group with the BCI for multiple, for all the vessels. So around 700 patients. And they found all the cause mortality was significantly differences and significantly lower in patient with the patient underwent PCI only for the culprit region, and later on before discharge they fixed the other physics. Move on to the operative concentration. Regarding the choice of the conduit, there is no differences actually in case of emergency cases. So you can take the Lima for the semi-patient in case of urgent case. Intraoperatively, the decompression of the left ventricle is very important. Why? Because decreasing the wall of tension and it will reduce the oxygen consumption and decrease the muscle damage and improve the functional outcome. And if you look for that, the oxygen requirement and oxygen decompression is lower with the cardioplegia compared with the beating or the other groups. If you see that the number B, the patient with the vented actually is better, the requirement for oxygen is lesser than the other group, which is indicate the patient should go to bypass as fast as possible to decompression of the left ventricle, and better to the vent of the LV. So the reduced oxygen consumption and ventricular decompression reduce the cardiopulmonary bypasses, reduce the oxygen consumption around 60%, and the cardioplegia, the arrest of the heart is reducing around 30%, with the cooling of the patient and reduce remaining 10% of the oxygen consumption. So what's the role of the intra-aortic balloon pump in cardiogenic shock after acute MI? So as we mentioned before, the routine use of intra-aortic balloon pump with the cardiogenic shock is not recommended. But here is routine use of intra-aortic balloon pump. If you look for the trial, in guidelines 2013, they downgraded of intra-aortic balloon pump and cardiogenic shock from class 1 to class 2A. And the intra-aortic balloon pump shock trial 2, they randomized a patient with acute MI complicated with cardiogenic shock who undergoing the early revascularization and optimal medical therapy to the patient intra-aortic balloon pump versus patient with non-intra-aortic balloon pump. Around 600 patients, they randomized to patient underwent revascularization without intra-aortic balloon pump and patient received intra-aortic balloon pump. And but keep in your mind that most of the patient is underwent PCI. Only 3 patients is underwent Cabbage. So after that, they found the all-cause mortality as the all-cause mortality and all the events in 6 years is not significant differences with the intra-aortic balloon pump versus non-intra-aortic balloon pump. So the 30-day outcome, no survival benefit with intra-aortic balloon pump, and around 6 to 12 month follow-up, no significant differences in mortality and reinfarction or repeat revascularization. But in the using of intra-aortic balloon pump only for the hemodynamic stability of the patient, but in terms of survival, there is no benefit according to the literature and according to this trial. And they conclude the intra-aortic balloon pump, there is no effect on all-cause mortality at 6 years long-term follow-up. Mortality is still very high with the 2/3 of the patient with cardiogenic shock, and dying despite the revascularization therapy. So the recent 7 trials showed that the intra-aortic balloon pump may be beneficial effect on some hemodynamic stability, but didn't result in survival benefit. So the routine using of intra-aortic balloon pump in patients with cardiogenic shock is not recommended. Thank you so much. Any question? This topic mainly STEMI patient mainly is most of the patient underwent the PCI. This is the class 1 for this patient, and in conclusion of this topic, the mortality rate in patient underwent the Cabbage within 3 days after MI is higher than patient if he undergo the Cabbage more than 1 week. So it's still controversial, but most of the surgeons prefer to wait for the enzymes to come down to stabilize the heart more, and then do the surgery later on after stability of even the myocardium will be more stable and less fragile, and the cardiac enzymes will go down. So still the studies is not there is no clear evidence about that, but according to the literature and retrospective studies is higher mortality within 3 days. Any question or comment?
Yes, I have a comment.
Yes,
regarding culprit lesions after MI, I think lots of efforts has to be done to open the vessel and open the culprit region by invasive cardiologists. and then you can deal with the rest of the anatomy on a later date.
Yes.
There is some kind of also things which is not proven yet, but it's been practiced while ballooning the culprit vessel only to establish a TIMI3 with a residual stenosis is also beneficial. And I've seen it done, and I was involved with those kind of cases where they balloon the vessel just to establish TIMI3 in those vessels, and then you can take them for cabbage in 3 to 5 days after settling the enzymes.
يعني بالون دكتور بالون يعني just to avoid using of Blavix.
Yeah, you just balloon this, and then you don't have to have a Blavix, you don't have to have this, and then you just wait for 3 to 5 days, and then you do your cabbage even on that vessel which was open because there is a residual stenosis in it. Some cardiologists don't like this, and some people they don't like it because they say that the vessel will reocclude again. I haven't seen it, but this is an argument, and then you have to reach an agreement between you and the invasive cardiologist regarding this. But there is invasive cardiologists who are doing this and ballooning the coronary. The other thing is in trial shock and all these studies using the intra-aortic balloon pump, and I remember we discussed this before, Abdulaziz. I think using the intra-aortic balloon pump still has a place in it for hemodynamics stability, for resting the heart, decreasing the afterload, because there are sequel. Maybe it doesn't increase the survival, but I think it expedites the recovery of the patients.
Yeah. Yes.
I believe strongly that intra-aortic balloon pump should be used almost always routinely in patients who were sick and came with a cardiogenic shock. Cardiogenic shock means hypotension.
Yes.
You have to increase the pressure. You have to afterload the heart. You have to do this. These things are done by anatropic support plus intra-aortic balloon pump. And to expedite the recovery of those patients, I think intra-aortic balloon pump should be considered.
Yes, Doctor.
I remember one of my people who trained me. He said to me, if intra-aortic balloon pump comes in your mind, like if you see a sick patient and intra-aortic balloon pump comes in your mind, comes up in your mind, and you say, shall I put it or don't put it? Put that balloon. So I'm very liberal in intra-aortic balloon pumps, and I think it should be almost always routinely used. Thank you.
Thank you, Dr. Abdulaziz. Yes, yes, I agree. Because in the guidelines they mentioned if the patient hemodynamically unstable, the intra-aortic balloon pump is class 2A. But routine using of intra-aortic balloon pump in any patient with the STEMI patient, even with the hemodynamically stable patient, is not recommended. This is what I understand from the guidelines, because they wrote as routine use of intra-aortic balloon pump in acute coronary acute coronary syndrome is not recommended. But on the other hand, if you look for the AHA guidelines, the using of intra-aortic balloon pump in hemodynamic in patient with unstable is class 2A. So yes, if the patient is unstable and hemodynamically, we have to stabilize him with pharmacological inotropes or mechanical support in terms of intra-aortic balloon pump. Any question, any comment?
Is there another lecture going, or?
I think there is. We have the coronary trial with Khalid Al-Garni after this lecture.
Dr. Aziz, do you have any questions for me? I'm Dr. Shabir.
Thank you so much, Dr. Shabir. I would like thanks for Dr. Shabir and Dr. Abdulaziz Baradei, our consultant in King Fahd Medical City, for their time and attending our teaching activity. Thank you so much, and thank you for Dr. Bakir for attending from King Khalid University Hospital.
Me and Baradi, we are in the same office, so it was a nice presentation. So if you have any questions, you can ask Aziz or anybody in the group.
Since nobody has question, thank you, Dr. Shabir and Dr. Baradei. We'll have a quick break for like 5 minutes, and then we'll start with the last lecture.
Thank you, guys.
Khalid. خالد.
نعم.
تفضل.
Assalamu alaikum. My name is Khalid Al-Garni. I'm from King Fahd Medical City. My talk today will be about coronary, and I'll speak also about Ruby trial. This is the outline of my talk. We'll speak mainly about coronary at 30 days, 1 year, and 5 years follow-up, Ruby, and extended follow-up study. Starting with the coronary trial, it is a randomized controlled trial, included a total of 4,752 patients for whom Cabbage was planned and randomly assigned to undergo the procedure on pump or off pump. It's a multi-center, around 79 centers across 19 different countries. The primary composite outcome for the trial was death, MI, stroke, or new renal failure requiring dialysis at 30 days. And this was also assessed at 1 year. And the second co-primary consisted of the first co-primary plus the rate of repeat revascularization at 5 years. Surgeons in this study must have more than 2 years of experience and have done at least 100 cases in the technique being used. For selection of patients, patients who undergo randomization for this patient were eligible to participate in the trial if they required isolated Cabbage with median sternotomy and had one or more of the following risk factors: age of 70 or more, peripheral arterial disease, cerebrovascular disease, or carotid stenosis of 70 or more of the luminal diameter, or renal insufficiency. Patients 60 to 69 years of age were eligible if they had at least one of the following risk factors, whether diabetic requiring treatment with oral or insulin, the need for urgent revascularization after an acute coronary syndrome, left ventricular ejection fraction of 35% or less, a recent history of smoking within the last year of randomization. Patients 55 to 59 years of age were eligible if they had at least 2 of those above mentioned risk factors. And the criteria for exclusion were a planned valve surgery, any contraindication to either off-pump or on-pump Cabbage, a decision by surgeon that one of the 2 techniques was not feasible for the patient, and life expectancy of less than 2 years, and emergency or repeat Cabbage surgery. So out of the 4,752 patients underwent randomization, 2,375 were assigned to off-pump Cabbage, and 2,377 were assigned to on-pump Cabbage. And here we can see the around 184 from the off-pump arm converted to on-pump Cabbage, and 150 converted to off-pump Cabbage in the on-pump arm. This table demonstrates the baseline characteristics of patients. We can see that majority of the patients' characteristics were matched between both arms, with mean age of 67 years of age in both arms, and about 80% of them were male. Also, majority of them, or nearly 47%, were diabetics. If we looked at the ejection fraction, around 70% had an ejection fraction of more than or equal to 50%, and nearly a quarter of them had an ejection fraction of 35 to 49%. And if we looked at the coronary artery disease, patients with left main were about 20 to 22% in both arms, with triple vessel disease 56 in the off-pump arm versus 60% in the on-pump arm. Here is a subgroup analysis for patients, different patient characteristics between both arms, and the majority of them were matched with no significant difference between both arms. For the outcomes at 30 days, we can clearly see that there's no significant difference between the two groups in the rate of primary composite outcome of death, non-fatal stroke, non-fatal MI, or new renal failure requiring dialysis. And if we looked at each of them, incidence of death occurred in 2.5% in the off-pump versus 2.5% in the on-pump. MI 6.7 versus 7.2. Rate of stroke 1% versus 1.1%. And new renal failure requiring dialysis 1.2% in the off-pump versus 1.1% in the on-pump arm. But if we looked at some secondary endpoints, including, for example, rate of bleeding, acute kidney injury, and respiratory complications, were favoring off-pump Cabbage. And fewer grafts were performed in the off-pump Cabbage than in the on-pump Cabbage, 3% versus 3.2, with a p-value of less than 0.001. And the rate of incomplete revascularization as assessed by the surgeon at the time of surgery was higher, though the p-value for the difference was only marginally significant, 0.05. And the off-pump surgery was associated with shorter duration of surgery, 4 hours versus 4.2 hours, and shorter duration of ventilator support, 9.6 hours versus 11.2 hours. And the rate of transfusion of blood products was significantly reduced in the off-pump group, 50.7% versus 63.3% in the off-pump group. And all these were secondary endpoints, and nothing from the primary composite endpoint were significant at 30 days. So if we looked at the outcomes at 1 year, also we can clearly see that there is no significant difference with respect to the primary composite outcome in the off-pump group versus on-pump group. And the primary outcome occurred in 12.1% in off-pump Cabbage versus 13.3% in the on-pump Cabbage. Even if we took each one of the components for the primary outcome, nothing were statistically significant between both arms. But if we looked at the rate of repeat revascularization at 1 year, we can see in the off-pump Cabbage, it's 1.4% versus 0.8% in the on-pump Cabbage, with a p-value of only 0.07. So there was no significant difference between the off-pump and on-pump Cabbage with respect to the 30 days rate of death, MI, stroke, or renal failure requiring dialysis. And the use of off-pump resulted in reduced rate of transfusion, reoperation for preoperative bleeding and respiratory complications and acute kidney injury, but also resulted in increased risk of early revascularization. This was at 30 days. At 1 year after Cabbage, there was no significant difference between the off-pump and on-pump Cabbage with respect to the primary composite outcome. Also for the quality of life and neurocognitive function were assessed at 1 year with no significant difference between both arms. For the outcomes at 5 years, which was published in 2016, we can see that the rate of primary composite outcome were not significant between on pump versus on pump, with death occurred in 14.6% versus 13.5% in the off pump versus on pump group. But if we looked at the rate of revascularization, repeat revascularization, it's also 2.8% versus 2.3% at 5 years, which was not statistically significant. And if we looked at the rate of stroke, it's 2.3% in the off-pump group versus 2.8%, which is not statistically significant. But keep in mind that there was a crossover between both arms, and there was a crossover from the on-pump group due to calcified aorta, and that could be related to possibly no stroke difference between both groups. So they conclude for the 5 years follow-up of coronary trial that the rate of composite outcome of death, stroke, MI, or renal failure, or repeat revascularization at 5 years of follow-up was similar among patients who underwent off-pump Cabbage and those who underwent on-pump Cabbage. And there was also no significant difference in cost or quality of life. Moving to Ruby trial, which is a randomized controlled trial, a US-based in 19 different centers with included only Veterans Affairs Hospital. Out of 9,663 patients were assessed for eligibility, only 2,203 were randomized to both arms of the study, where 1,104 in the off-pump Cabbage and 1,099 patients in the on-pump group. And nearly the inclusion criteria were the same. Patient having isolated Cabbage, elective or urgent, and patients were excluded for if they have a planned valve surgery, immediate surgery, or a small target diffuse coronary artery disease, high risk of adverse events, and being unable to provide informed consent. So the patency, out of the 1,000, nearly 1,000 patients in both arms, nearly 60% of them had angiographic follow-up at 1 year, 600 out of the original 1,100, and 685 out of the 1,099 patients had angiographic follow-up at 1 year. So they assessed the patency for both groups at 1 year, and which showed that off-pump Cabbage resulted in lower Fitzgibbon A patency rates, which indicate a patent flow in the off-pump versus on-pump Cabbage for arterial conduit, 85% versus 91% in the on-pump Cabbage, and Saphenous vein graft 72.7% versus 80.4% with a p-value of less than 0.001. And also fewer off-pump patients were effectively revascularized, 50.1% versus 63.9% in the on-pump with a p-value of less than 0.001, and within each major coronary territory, effective revascularization was worse in the off-pump than on-pump. So based on these initial finding at the 1 year graft patency being lower in the off-pump Cabbage, lots of questions being raised about the long-term efficacy, durability of this technique. So they conducted a 5-year follow-up study for the initial Ruby trial. And the two primary 5 years outcome were death from any cause and a composite outcome of major adverse cardiovascular event, MACE, defined as death from any cause, repeat revascularization, whether Cabbage or PCI, or non-fatal MI. And the secondary 5 years outcome included death from cardiac causes, repeat revascularization, and non-fatal MI. Same diagram that we had before. And if we looked at the baseline characteristics for patients, majority of them were elderly with mean age of 63, 62 years of age. And majority of them, nearly 99%, were male patients. And nearly half of them were diabetic, and majority of them were hypertensive. And if we looked at the ejection fraction, nearly or more than 59 of 58% had an ejection fraction of more than 54%, and around 23% having ejection fraction of 45 to 54%. Here, if we looked at the 5 years extended follow-up for the original Ruby trial, if we looked at the primary outcomes of all-cause mortality, it was here we can see the survival in on-pump versus off-pump group, which led to lower rate of survival in the off-pump Cabbage versus on-pump, and freedom also from MACE or major adverse cardiovascular event were higher in the off-pump Cabbage versus the on-pump Cabbage. So we saw that mortality at 5 years was significantly lower in the on-pump, and the off-pump Cabbage led to lower rates of 5-year survival and event-free survival than on-pump Cabbage, and no difference in the secondary outcome indicated benefit of off-pump Cabbage. But we can clearly see that the number of patients included in this trial, nearly half of the numbers in the original coronary trial, 2,000 versus 4,000, and only around 60 to 64% of them had angiographic follow-up at 1 year. And there was a selection bias in this trial. Only Veterans Affairs Hospital were included in this trial. Unlike the coronary trial, we can see the apparent difference between Ruby, which showed a significant higher rate of a composite outcome at 1 year with off-pump and coronary, and that may be due to difference in the experience level of surgeons in the Ruby trial only needed 20 cases of experience. Unlike coronary, they have to have at least 2 years of experience plus at least 100 cases done. And we can see also the difference in the baseline characteristics of for the risk of patients. Patients were sicker in the coronary trial. Any other studies? Yes, this is a diagram. It is a retrospective analysis from the original Excel trial among patients with left main disease. We can clearly see that off-pump Cabbage resulted in a higher risk of 3 years all-cause mortality compared to on-pump, and also resulted in a lower rate of revascularization of coronary arteries supplying the infralateral wall. And they came across different meta-analysis. One of them is a recent meta-analysis of 12 randomized controlled trial with a follow-up beyond 1 year. It showed a significant increase in the off-pump group looking at the rate of repeat revascularization. Another large Korean study included nearly 5,000 patients with long-term survival and median follow-up of 6.4 years also favors the on-pump Cabbage. So based on the previously mentioned studies, we can clearly see that the survival advantage consistently associated with on-pump over off-pump Cabbage has been attributed to the higher rates of incomplete revascularization in the off-pump and worse graft patency with off-pump compared to on-pump Cabbage observed in different randomized control trial and retrospective studies. A debate is ongoing as to the potential long-term benefit of off-pump Cabbage, and we need more and further studies and longer follow-up to address this issue. And as a final take-home message, patient management should always be individualized based on the clinical history and presentation of the patient. And on-pump is still the standard of care, except for selected cases like porcelain aorta, where the off-pump resulted in less manipulation of the ascending aorta and hence less risk for the aorta emboli. This was the end of my talk. Thank you. Any comments?
I have no comment. I have nothing, but I have to say, just debate on pump and off pump is going for years and years. And I believe strongly, if you want to be a coronary surgeon, you have to choose. Either you want to be an on-pump surgeon or off-pump surgeon. I know surgeons who are good at off-pump Cabbage, and they are doing full revascularization, and they are okay, and their results are good. But the problem with off-pump surgery is someone who does on-pump surgery and then one case as an off-pump or something like this. I don't think that's a very good idea. I think you have to choose if you are on-pump or off-pump. For porcine aortas and no-touch technique, there's other procedures you can do for this as an on-pump surgeon, but it's preferable to be off-pump surgery also. So that's, I would give you the take-home message. When you grow up, choose, you want to be an on-pump surgeon or off-pump surgeon. And before you do off-pump surgery, you have to have a good training in this. And you choose to be a sole off-pump surgeon. Mixing is not a good idea. Thank you.
Thank you.
لو تسمحوا لي امشي خلاص. Have a nice weekend everybody وشكرا جزيلا.
Thank you, Dr. Baradi. Sorry, thank you so much.
Okay, any comment or question for Khalid? Dr. Shabir, any comment from your side?
Yeah, I think it's just, it's mixing.
You close? Okay.
Yeah. Mixing is not a...
Okay, so by this we will conclude our session for today. Thank you.